Good morning, everyone. My name is Jackie Gordon, and welcome to my final DNP project presentation on postoperative glycemic control in the cardiac surgery patient. I'd like to take a moment to acknowledge my committee. I would not be here today without you. I'd also like to thank Dr. Vicki Sherm, who is my site mentor, for her expertise in guiding my project. A little bit of background related to my project. All patients, there are approximately 500,000 cardiac surgeries performed in the United States every year, and all patients undergoing cardiac surgery are at risk for hyperglycemia. This hyperglycemia that occurs following surgery is associated with poor postoperative outcomes, including surgical site infection, increased length of stay, prolonged mechanical ventilation, and even death. These poor outcomes are then translated into increased healthcare costs. Greco and colleagues found that cardiac surgery patients with postoperative infections resulted in $38,000 of additional index hospitalization costs. And of those patients who had infections, 8.7% of those who had infections were readmitted, and their readmission was associated with a 2.6-fold higher cost than those readmitted for other reasons other than infection. So to combat the deleterious effects of hyperglycemia, using a continuous insulin infusion versus subcutaneous administration of insulin has been found to be more effective at preventing hyperglycemia. So nurse or computer-managed continuous insulin infusion protocols are administered as standard of care following cardiac surgery to prevent hyperglycemia and its subsequent untoward outcomes. However, the target blood glucose range remains controversial. Strict glycemic control with low targets were employed in the early 2000s following a landmark study by Vandenberg and colleagues. However, recent studies have found that more liberal targets have shown equivalent postoperative outcomes, but have prevented hypoglycemia that has been found when employing strict continuous insulin infusion protocols. Two landmark studies are worth noting regarding hyperglycemia following cardiac surgery. Vandenberg and colleagues carried out the first landmark randomized controlled trial in 2001 to evaluate the outcomes of strict and liberal glycemic targets using continuous insulin infusions in critical care patients. They enrolled 1,500 critical care patients, 65% of which were cardiac surgery patients, and they found that there was a significant difference in mortality. 8% of patients in the liberal continuous infusion group died, compared to only 4% of those in the strict group died. However, it is important to note that all patients during this trial were receiving a concomitant dose of dextrose. 8 years later, the NICE sugar trial study results were published in 2009. This was a study that enrolled 6,000 critical care patients. There were, however, a smaller number of cardiac surgery patients. These researchers found that patients were actually 1.14 times more likely to die when receiving the strict continuous infusion protocol versus a liberal protocol. So the results of the NICE sugar trial swiftly gained attention of those in practice settings who had previously implemented strict continuous infusion protocols based on Vandenberg study results in their cardiac surgery patient population. When synthesizing the literature together, outcomes of interest to this project were evaluated. Hypoglycemia was found to be increased in patients receiving strict protocols. Overall, there were equivalent outcomes of surgical site infection, ICU length of stay, and mortality when comparing those receiving a strict continuous infusion protocol and those receiving a liberal continuous infusion protocol in the cardiac surgery patient population. There are also clinical practice guidelines to guide those in the practice settings. The Society of Thoracic Surgeons published guidelines in 2009 recommending that blood glucose levels remain less than 180 milligrams per deciliter in the first 24 hours postoperatively using a continuous insulin infusion protocol, and to maintain that blood glucose of less than 180 for the duration of the hospital stay. In 2012, the Society of Critical Care Medicine suggested that blood glucoses should remain less than 150 milligrams per deciliter in the postoperative period following cardiac surgery. When looking at all of the studies synthesized together, it is very difficult to know what target glucose range we are to achieve in the practice setting. Strict and liberal continuous infusion targets varied greatly throughout the studies reviewed, and they also overlapped. This causes increasing confusion for practitioners at the bedside. In addition, there were gaps in the literature as education of frontline staff administering the protocols and adherence to these protocols was rarely reported. Description of the actual protocols used to achieve the blood glucoses were rarely reported, and only the target range of what they were trying to achieve was reported, not the actual blood glucoses, as these were only reported in a few studies. And finally, there were very different methodologies. Some studies used administration of parenteral or enteral nutrition during insulin administration. So there are definitely additional large multi-site randomized controlled trials with only cardiac surgery patients needed using the same blood glucose ranges. And the designs need to carefully address the nutrition, as this isn't done routinely in the practice setting. So this leads me to my project problem. In December of 2014, an evidence-based liberal continuous insulin infusion protocol was implemented in the project setting based on STS guidelines. This was implemented in efforts to avoid hyperglycemia while preventing hypoglycemia and reduce surgical site infections, ICU length of stay, and mortality. A quality improvement project in the project setting revealed that the previous strict continuous insulin infusion protocol was outdated, as the most recent literature suggests a liberal protocol will provide the same outcomes while preventing hypoglycemia. The quality improvement project also revealed that nurses in the project settings perceived they would induce hypoglycemia, leading them not to adhere completely to the written protocol. The clinical outcomes of the new liberal continuous insulin infusion protocol were unknown, and it was unknown if the incidence of hypoglycemia was decreased with the use of the new liberal protocol. So the purpose of this project was to evaluate the effectiveness of a liberal continuous insulin infusion protocol compared to the previous strict continuous insulin infusion protocol that had been implemented in the project setting. The clinical outcomes to be evaluated were surgical site infection, ICU length of stay, and 30-day mortality. In addition, actual blood glucoses achieved and incidence of hypoglycemia were evaluated for both protocols within the first 24 hours following surgery. The PICO question related to this project was, in postoperative cardiac surgery patients admitted to the Heart and Vascular Critical Care Unit, was a revised postoperative continuous insulin infusion protocol with the goal of maintaining blood glucose levels 140 to 160 milligrams per deciliter, compared to the previous continuous insulin infusion protocol with the goal of maintaining blood glucose levels 100 to 140 milligrams per deciliter in the first 24 hours, decrease the incidence of hypoglycemia while maintaining similar surgical site infections, intensive care lengths of stay, and 30-day mortalities. So the outcome variables of interest to this project are hypoglycemia, which is defined as a blood glucose of less than 70 milligrams per deciliter, Surgical site infection, defined as an infection that occurs 30 days postoperatively and meets National Healthcare Safety Network definition criteria for a surgical site infection. ICU length of stay, measured in days, which is date and time of ICU admission to date and time of change in level of care from intensive to either intermediate or floor status. And finally, mortality, which is defined as death at 30 days. The hypotheses related to this project were that there are no differences in outcomes of surgical site infection, ICU length of stay, and mortality in postoperative cardiac surgery patients receiving a strict continuous insulin infusion protocol compared to those receiving a liberal continuous insulin infusion protocol. The second hypothesis is that the incidence of hypoglycemia will be decreased in those receiving a liberal continuous insulin infusion protocol. The model used to guide this project was the A-STAR model of knowledge transformation, which is an evidence-based practice project model. Specifically, Stage 5 process and outcome evaluation were used for this project. The method used to carry out this project was a retrospective medical record review. A quantitative analysis was carried out on data retrieved from the medical record and also separate databases. The setting for this project was a 30-bed heart and vascular critical care unit located in a 551-bed academic medical center located in central Pennsylvania. To perform the medical record analysis, an electronic program, Business Objects InfoView for systems, applications, and products and data processing was used. This electronic query was used to obtain baseline demographics, including age, gender, diagnosis of diabetes, type of surgery performed, and body mass index. In addition, date and time of ICU admission and discharge, and blood glucoses within the first 24 hours and the entire critical care stay were retrieved. Following the electronic medical record query, unique identifiers were used to query the NHSN database for surgical site infections and the STS database for 30-day mortalities. IRB approval was achieved in May 2015, and the status of this project was exempt. And the nature of this project is a retrospective medical record review, so securing data was of utmost priority. Data was kept in password-protected files and access-only folders on the Penn State Hershey network. Subjects included in this study were postoperative cardiac surgery patients admitted to the heart and vascular critical care unit, and cardiac surgery patients were included who received the strict continuous insulin infusion protocol between June 1st, 2014 and December 31st, 2014, and those cardiac surgery patients who received the liberal continuous insulin infusion protocol between March 1st, 2015 and September 30th, 2015. Inclusion criteria were those patients with or without a diagnosis of diabetes, patients greater than 18 years old, those who had a coronary artery bypass graft surgery, a valve surgery, or a combination of the two. And exclusion criteria were those patients who had emergent operations, cardiac transplants, ventricular assist device implantation, those who died in the operating room, or stayed in the ICU for greater than 30 days. A statistical analysis was performed. Demographic data was analyzed using a t-test for continuous variables, including age and BMI, and a Fisher's exact test was used for categorical data, including gender, diabetes, status, and type of surgery. Outcomes were statistically analyzed between groups, and the outcomes that were analyzed included hypoglycemia, blood glucose means, surgical site infection, ICU length of stay, and 30-day mortality. Fisher's exact test was used to compare the proportion of hypoglycemic values in the first 24 hours following surgery, the proportion of surgical site infections, and proportion of 30-day mortalities. A t-test was used to evaluate blood glucose means in the first 24 hours and ICU length of stay, which was measured in days. A total of 148 patients underwent cardiac surgery and received the strict continuous insulin infusion protocol between June 1st, 2014 and December 31st, 2014. 4 patients met exclusion criteria, leaving a total of 144 patients in the strict group. A total of 149 patients underwent cardiac surgery and received the liberal continuous insulin infusion protocol between March 1st, 2015 and September 30th, 2015. 2 patients during this time period met exclusion criteria, leaving a total of 147 patients in the liberal continuous insulin infusion group. The baseline characteristics of the 2 groups are depicted in the current table. The groups were similar and there were no significant differences between demographic characteristics of the strict and liberal groups. Blood glucoses within the first 24 hours in the mean blood glucose within the first 24 hours in the strict continuous insulin infusion group was 143.3 milligrams per deciliter, and in the liberal group, it was 159.8 milligrams per deciliter. These were significantly different. 48.5% of blood glucoses in the strict continuous insulin infusion group were within target range of 100 to 140 within the first 24 hours, and only 24.7% of blood glucoses were within target range in the liberal continuous infusion group within the first 24 hours. Clinical outcomes are depicted in the current table. The outcomes of interest were surgical site infection, and there were no surgical site infections that occurred in either group. ICU length of stay was 4.4 days in the strict cohort compared to 4.5 days in the liberal cohort and did not differ between groups. There were no 30-day mortalities in the strict group compared to 2 30-day mortalities in the liberal group, and these also did not differ. The incidence of hypoglycemia was low in both groups. There were 10 incidences in the strict group compared to 3 in the liberal group. There was no significant difference in hypoglycemia when comparing the strict protocol to the liberal protocol. Results of this medical record review and quantitative analysis support the first hypothesis that the outcomes of surgical site infection, ICU length of stay, and 30-day mortality would not differ between those receiving the strict continuous insulin infusion protocol and those receiving the liberal continuous insulin infusion protocol. The hypothesis that the incidence of hypoglycemia would be lower in the strict group was not supported by the results of this project. There were more incidences of hypoglycemia in the strict group, 10 incidences in 7 patients, compared to the liberal group, where there were only 3 incidents in 3 patients. However, this was not statistically significant. The strict continuous insulin infusion in the project setting had a higher low target range, 100, compared to the majority of strict continuous insulin infusions reported in the literature, most of which started at 80. This could explain the low incidence of hypoglycemia in the strict group. This project supports current STS recommendations to implement liberal continuous insulin infusion protocols for 24 hours following surgery in the cardiac surgery patient population. More research is needed using prospectively collected data, evaluating multiple protocols to determine the optimal glucose range. Interprofessional evaluation of the current liberal continuous insulin infusion protocol is warranted in the project setting. There is much work to be done. Only 24.7% of blood glucoses in the first 24 hours were in target range with the liberal protocol, which is currently in place in the project setting. Further evaluation of blood glucoses prior to and beyond 24 hours following surgery is warranted, as STS recommendations suggest that glycemic control should be commenced prior to surgery and follow the patient throughout discharge. Finally, measuring continuous insulin infusion protocol adherence was not able to be done during this project, and in the future should be done. The primary limitation of this project is that it was retrospective in nature. In addition, it was a medical record review. Values entered into the electronic medical record can be entered in error, producing false data. Furthermore, the NHSN database was used for surgical site infection data, and the STS database was used for 30-day mortality data. While both abstractors employed in the project setting undergo training regarding the use and abstraction methods, there's always a chance for errors. Furthermore, the STS database entries rely on finding data not readily available in the project setting medical record, but reports of death through Social Security data and obituary searches. There is a potential not to identify a subject dead at 30 days. Finally, this project limited the review of blood glucoses to the first 24 hours postoperatively. Due to kind constraints, the entire postoperative inpatient blood glucose evaluation was not undertaken. Optimal outcomes are achieved when glycemic control is carried out throughout the entire perioperative course, including preoperatively until discharge from the hospital. In conclusion, the liberal continuous insulin infusion protocol employed in the project setting provided similar outcomes of surgical site infection, ICU length of stay, and 30-day mortality. The incidence of hypoglycemia was low in both the strict and liberal continuous insulin infusion groups. There is much work needed in the project setting to further evaluate the liberal continuous insulin infusion protocol, as only 24.7% of blood glucoses achieved were within target range in the first 24 hours following surgery. And globally, more research is needed to identify the optimal liberal target blood glucose range following cardiac surgery. And here are my references. And thank you for your time.